My name is Anissa Mitchell, and I'm with PMD Alliance, and I'm very excited today to introduce to you Dr. Galit Kleiner. She is a movement disorder specialist in Toronto, Canada at Baycrest Movement Disorders and MS Clinic. Now, she started her career after her fellowship training here in Pennsylvania in the United States as the clinical director of the Parkinson's Disease Research, Education, and Clinical Center. Then she returned to Canada, where she's currently serving. Dr. Kleiner is doing some very interesting research, and some of that she's going to be discussing today. She's very interested in quality of life and geriatric movement disorders, is involved in several research initiatives exploring how non-motor fluctuations in Parkinson's disease impact quality of life. She developed and validated a tool for capturing non-motor fluctuations called the NOMOFA, if I'm saying it right. It's actually now a licensed questionnaire up on the Movement Disorder I'm having trouble talking, the Movement Disorder Society website. And it is helpful in enhancing the empowerment of people and understanding their motor fluctuations. So she's going to be talking about that today. Yes, we do have some Canadians in the house, Dr. Kleiner, so I'm excited to hear that. Wonderful. So I am going to pass this over to her and let her get you started.
Okay, so I'm just going to share my screen. Let's see if we've already tried this. Yes, it looks like I'll succeed this time. Hold on.
We did some practice. And please, everyone, ask your questions in the chat. That's why another reason why I wanted you to open it up. So we'll hold those until the end. I'll collect those and then we'll go through those after Dr. Kleiner's presentation.
Okay, the only thing is that I realize that this is in my slide. Sorry, I'm just going to see if I can reorient. Let's see. I may have to, yeah. So one thing we didn't figure out is that the slides, that the views of everyone, okay, there we go. I moved it. Now I can't see anybody. I guess you guys can hopefully still see me. Let me just start here.
We see you and we see the slides perfectly.
You see me and you see the slides. Now the only question is how I'm going to move the slides. There we go. All right. Okay. Sorry for that. I'm not technically that adept. So my name is Galit Kleiner. I am a movement disorders neurologist. As Anissa had described, I'm actually American to start with, but grew up in Canada, went back and forth, did my training in Boston, my fellowship in Toronto, and then, as Anissa said, I started my career in Pennsylvania at the University of Pennsylvania. So this project actually started there, which I will discuss a little bit more as we move into the talk. Today's subject is non-motor symptoms in Parkinson's disease, focus on non-motor fluctuations. So thank you very much for this opportunity, this privilege to speak to you about this subject matter today. So these are just my disclosures. My goals today are for the audience to recognize the clinical spectrum of non-motor symptoms and a subset of non-motor symptoms, non-motor fluctuations. I'm going to introduce and discuss the non-motor fluctuation assessment questionnaire, the NOMOFA, which is the first validated instrument to capture and quantify non-motor fluctuations. And then I hope you're going to gain familiarity with identification and therapeutic strategies to reduce non-motor fluctuations. And I'm going to present a case that will hopefully outline some of these strategies. So I'll start the lecture with this historical essay. So this is the cover of the original description of Parkinson's disease by James Parkinson in his 1817 essay on the shaking palsy. In it, he describes the now well-recognized features of Parkinson's disease, including tremors, stooped posture, gait impairment, and bradykinesia, or slowness of movement. Though Parkinson's has traditionally been thought of as a condition affecting movement, Dr. Parkinson already then, in 1817, drew attention to some non-movement symptoms experienced by his patients, for example, sleep disturbance and constipation. So this table provides a broad list of non-motor symptoms that people living with Parkinson's may experience. It's categorized into neuropsychiatric, cognitive, autonomic, that means the involuntary nervous system, sensory, and sleep domains. Not every person experiences all these symptoms, but we recognize now that most people experience one or more non-motor symptoms, and the impact of non-motor symptoms may affect quality of life even more adversely than motor symptoms. So this table that I've got up here, it confirms this assertion that I just made. This paper was published earlier this year using the MDS-NMS, so Movement Disorder Society Non-Motor Symptom Questionnaire, to survey nearly 400 patients living with Parkinson's as to which non-motor symptom they experienced and to determine the prevalence. And the study found that 99.7% of people living with Parkinson's endorsed experiencing symptoms of non-motor symptoms. Now, non-motor fluctuations are an associated but distinct clinical phenomena from static non-motor symptoms, and it occurs in patients with Parkinson's disease who take levodopa. So this could be very confusing to patients and clinicians alike, because a static and a fluctuating non-motor symptom may be the same symptom, for example, anxiety, which may occur all the time, but may also still fluctuate in severity according to the timing of when you take levodopa. However, the static versus the fluctuating symptoms may have different underlying pathophysiology, that means caused by different underlying brain mechanisms, whereby fluctuations are dopaminergically mediated, and static symptoms may be mediated by serotonergic, adrenergic, and cholinergic neurotransmitter systems. Even more confusing is that both static and fluctuating symptoms may coexist in the same person. Not surprisingly, patients, caregivers, and their physicians may have a difficult time recognizing which symptoms are static, which fluctuate, and when. But it's important to distinguish them, as treatment for static and fluctuating symptoms are different, with fluctuating symptoms responsive to optimization of dopaminergic medications. So this schematic serves to illustrate the concept of fluctuations in response to administration of levodopa. So levodopa is taken at a certain time point. So let me just see if I can use my, so like, let's say right here, after 20 to 30 minutes, its effect kicks in and symptoms of Parkinson's alleviate, which may last for a period of time, and then they wear off prior to the next dose. So kind of like here, and it's sort of this like roller coaster type shape. Notably, there are problematic fluctuations that occur in both the on and in the off state. So on means when medication is working, off means when medication is not working. And it's important to differentiate to know whether to reduce or increase medications. Fluctuations have typically been associated with a motor response or a motor fluctuation, but there are also non-motor fluctuations that occur predictably depending on dopaminergic tone. So as you can see here in this table, it talks a little bit about both the movement and the non-movement emotional cognitive symptoms that you may experience in the on and in the off state. Though as clinicians working with people that experience Parkinson's disease, we anecdotally observe this phenomena frequently, the actual prevalence of non-motor fluctuations and impact on quality of life in the larger Parkinson's population is unknown, as there's no valid, reliable tool to capture and quantify these symptoms. This study, which was performed back in 2002, surveyed 50 patients regarding their experience of non-motor fluctuations. While the survey was not tested for its clinometric properties, for example, its validity or reliability, the results were still quite impressive and compelling, suggesting that there may be a large proportion of people that were impacted by non-motor fluctuations, and for some of them, it was very disabling. It was at that time that I realized that the lack of a method to reliably identify and quantify non-motor fluctuations, due to the absence of a valid, reliable tool, resulted in a major gap in our armamentarium of treating troublesome symptoms and targeting therapeutics to alleviate these. Without proper measuring tools to determine the true and precise prevalence of non-motor fluctuation and their impact on quality of life, it'd be impossible to test novel treatments as to their impact on the set of troublesome symptoms. So in 2004, that was when I finished my fellowship, and I moved to Philadelphia at the Philadelphia VA. I started to work on what ultimately became the non-motor fluctuation assessment questionnaire, the NOMOFA. To generate items for NOMOFA, we conducted nominal group technique sessions, and that is a type of qualitative research methodology that brings together people living with Parkinson's, their caregivers, and a group facilitator in small groups to generate items and then vote on their importance. In the spirit of the voice of the patient influencing research protocols, we wanted the questionnaire to reflect patient experience, and hence we chose this method of item generation. Once we reached saturation with the small groups, meaning the same items were being suggested from new participants, we stopped conducting additional groups and we finalized a list of non-motor fluctuations. We reviewed this list with experts in the field to ensure that there weren't any other additional items that the experts also identified. And then we subsequently took this master list back to the patients that we had originally discussed the items with for their final endorsement. We also discussed the language and the formatting of the questionnaire in a focus group format before we finalized this initial questionnaire. And this table here to the right lists the 28 items that we generated in the process. So nearly 17 years after starting this project, this sort of labor of love, initially not too many people took that much interest in this, but sort of over time it became of greater interest as physicians and clinicians and patients started to recognize non-motor fluctuations. We did 2 large-scale validation trials across Canada and the US. Nearly 400 patients were included. And we published the final validation paper in March of 2021 in the Movement Disorder Society journal. The NOMOFA was officially endorsed and licensed by the International Parkinson and Movement Disorder Society, and it's now in the process of being translated into other languages and also validated in those other languages. The final 27 item self-administered NOMOFA questionnaire is valid and reliable. It captures static and fluctuating non-motor symptoms in Parkinson's for use in clinical and research settings. And future studies that we're currently undertaking are going to determine NOMOFA's sensitivity to change, meaning how well it captures change over time, and the minimal clinically important difference. So what score do you need to have a change in that's going to really reflect a change in your symptom burden? So this table is from our paper, and it demonstrates prevalence of non-motor symptoms and non-motor fluctuations in the cohort of patients that participated in the study. And one of the features of this questionnaire that is quite informative and unique is that it surveys both static and fluctuating non-motor symptoms within an individual, such that the treating physician is able to differentiate between these symptoms and therefore customize treatment. This is especially relevant as some non-motor symptoms that are static are quite difficult to treat. For example, a feeling of low energy or fatigue. And oftentimes when it's static, there's no really good solutions. However, while fatigue is the most frequent non-motor symptom endorsed, as seen in this table, it is also the non-motor symptom that fluctuates nearly half of the time that it's present. So this is actually really good news, as fatigue may improve if fluctuations are reduced. This is also true for those with other difficult symptoms listed in this table, including cognitive symptoms, which typically would have limited options to treat. So now I'm going to demonstrate sort of real life non-motor fluctuations. I'm going to describe a case of one of my patients, and I'm going to show some pictures and a video. And please note that, of course, there was consent provided to share the information and the videos. So, this lady, I saw her for the first time in 2014, and at that time she was 80 years old. Her main complaint was, I feel bad all the time. Her history of Parkinson's started back, I guess it was 2006, which had been 8 years earlier. And she had slowness and stiffness in her left arm, loss of sense of smell, and severe anxiety. Not an unusual presenting complex. A year later, she started to also then develop a resting tremor, a left-hand resting tremor, and she had difficulty walking and in fact fell and broke her hip. Her voice was soft, her face demonstrated flat affect, and it was at that time that her picture was pretty clearly Parkinson's disease and she was diagnosed. Then over the period of 2008 to 2014, she really struggled. She had numerous falls. She wasn't able to take her medications. She wasn't compliant with the treatment. She became increasingly housebound and spent most of her time in bed. She experienced severe anxiety and her family was just exhausted. She experienced a sense of shortness of breath and felt that she had palpitations, and she saw so many doctors, including cardiologists and pulmonary doctors, and nobody could find an explanation for her symptoms. So after a really long intake and trying to understand what was going on, which was really difficult because it was very difficult for her to really clarify what all her symptoms were and when they happened and so forth, I put together a problem list. I tried to put it in terms of motor on one side and non-motor on the other. So in terms of her motor symptoms, she had tremors, she experienced mobility problems, she had difficulty turning over in bed, she had foot dystonia where her toes curled, and that was quite painful. She had swallowing dysfunction, and she had involuntary movements. In addition, she frequently urinated at night. She was severely constipated. She experienced nausea, couldn't sleep, both having difficulty falling asleep and then having REM behavior disorder, where she had dream reenactment behavior, fatigue, hallucinations used to describe symphonies in her head. There was cognitive impairment. She was so anxious that she lay in bed, and that was part of the manifestation of I can't breathe. As I said, she had palpitations, she was lightheaded, she had fainted. Her family, as I mentioned, they tried so hard to help her, but they were really exhausted. As a result of all of this, she didn't eat much, she had poor hygiene. When I examined her, she had low blood pressure with a drop when she stood up, so orthostatic hypotension. We know that in Parkinson's disease, both the disease itself and the medications used to treat it can worsen this symptom and cause people to feel lightheaded and to faint. In the off state, it was very hard to understand what she said because her voice was so soft. She had minimal facial expressions, her hands were trembling, she was slow and stiff, and she just refused to speak. She just kind of stared off into space. This was in my office. Her posture was stooped. She had poor balance. Her feet got stuck. And then she took a dose of medication. Again, this was part of a very long assessment, so I got to see her in all her phases. And she changed completely. Her tremors were gone. She had much less bradykinesia, the slowness, rigidity. She was able to walk. She was conversant, coherent, though she did have some involuntary movements. This was a list of the medications she at least was prescribed. She was taking so many medications. The clonazepam, which is a sedative, is never a good medication to take for elderly people. She was taking so much levodopa and Stalevo at all, so many different times, and she wasn't able to really come up with any pattern of her symptoms. It was just kind of a mess. So because we weren't able to really differentiate on from off, meaning when did it happen, what time was it in relation to medications, and there were so many factors that contributed to those symptoms, we decided that we were just going to kind of start from scratch, put her on some kind of reasonable plan, and then monitor for her in terms of the impact of the strategy, and then try and derive some information from that strategy. So the initial plan was to put her on levodopa every 3 hours, taking 1.5 tablets. She had severe constipation. That's a major problem in Parkinson's and has to be aggressively treated. It's not something that we just say, oh, okay, don't worry about it. It's okay, it's there. It has to be aggressively treated. This relates to the fact that when people are severely constipated, that everything is backed up. There's already, because of Parkinson's disease, delayed gastric emptying. So as it stands, it takes food a long time to be digested. And as I hope some of you know, or many of you know, or most of you know, that protein interferes in the metabolism of levodopa or in the absorption. That means that if you take levodopa at the same time that you're eating, or you have protein in your stomach, your levodopa won't be absorbed as efficiently. And to compound this, if you're also constipated, that takes even longer. So you're really not getting optimal effects of the levodopa if you're severely constipated. She was also taking antihypertensive medications. So previously, I guess she had had high blood pressure. But now that wasn't the case, and that was probably contributing to her low blood pressure and her feelings of faintness. We stopped the antihypertensive, we supplemented her aggressively with salt and fluid. So it's not just have a little bit of salt on your dinner, it's have bouillon for breakfast, soy sauce, V8, potato chips. It's the sort of one time that you're allowed to eat all the things that you think you're not supposed to eat. And we added Seroquel at night. And Seroquel was a medication to address her hallucinations. And it also has as a side effect, making you a little bit sleepy, with the goal of consolidating sleep at night and reducing the hallucinations. We provided her with a motor diary, and that is basically a sheet of paper that has slots for every sort of time period in the day, asking her what time did she eat, what time did she take her pills, what time was she on, what time was she off, and asking her what were those symptoms during that time. Her anxiety was crippling, interfering in her ability to follow recommendations. And so we referred her to psychiatry. She had been taking clonazepam, popping it kind of like candy, which for elderly people it's a dangerous drug. It can make you confused. It can contribute to falls. It was not a good strategy for sleep for her, because a lot of her problem had to do with poor sleep at night, including the fact that she was getting up numerous times at night to pee. We referred her to a Parkinson-specific urologist as part of our network. We referred her to a Parkinson-specific cognitive behavioral neurologist, who's also a specialist in the thinking issues related to Parkinson's. We put her on melatonin, which is a good medication for the REM behavior disorder, the sleep reenactment. Discussed with her sleep hygiene, because she was going to bed at 2 or 3 o'clock in the morning after watching TV and so forth. Put all her medications in a blister pack, so she didn't have to be trying to figure out what pill to take when. And we involved our entire interdisciplinary team to support her: the speech language pathologist, the occupational therapist, the physical therapist, pharmacist, and dietitian, to really come up with a comprehensive plan that didn't just include medication, but included all holistic aspects of her care. And so many of you in the US don't know what a LIN is, but here it is in Ontario. It's one of the health integration networks. We sort of have a socialized medical system. I know many people in the US fear that, but I can tell you it's actually pretty good. We do pay taxes to cover it, but it provides a lot of services that people need. So we got her a PSW, a personal support worker, to come in every day to assist in her bathing and dressing. And this took some burden off her family. So after 2 weeks, we saw her again, and we were able to make some sense of her symptoms. She clearly did have fluctuations, and she clearly had good on periods, and then she would wear off. But when she was off, not only did she have mobility issues, slowness, and stiffness, she had all the non-motor symptoms that we talked about: nausea, crippling anxiety, shortness of breath, palpitations, urinary urgency. That's when she was bedbound. So we were able to clearly distinguish that this wasn't just, I feel bad all the time. It was that there are some specific periods of time when the Parkinson's medications was not optimized that resulted in her having these non-motor fluctuations in addition to motor fluctuations. So now we were kind of struggling, because there were many factors to consider in terms of what do we do now to ensure that she has less off times with less fluctuations without kicking her into dyskinesia and hallucinations, which just giving more medication would have done. And what we decided to do was sort of a clinical pearl that I learned from my mentor, who is one of the greats of Parkinson's disease, Dr. Tony Lang. And I trained with him, and sort of when we got to the point where we had sort of exhausted every other option, we would try liquid levodopa. And liquid levodopa is basically just taking levodopa, putting it in water, and then being able to more precisely fractionate the levodopa. Now, I think that in the US, in Canada, this doesn't exist, but I think in the US, there are products where you can take smaller increments of levodopa, such that you're not just limited to either 50 milligrams or 100 milligrams or 200 milligrams. So in Canada, we are limited in that way. And the way we get around it is by using liquid levodopa. So we calculated how much, we took the total amount of levodopa that she was taking in a day, and then we fractionated it into those 2-hour intervals because she was wearing off after 2 hours. I didn't want to give her more medication overall because that could cause her more side effects. And so she started to take 135 milligrams in liquid form every 2 hours between 9 a.m. and 11 p.m. And then we gave her one dose in the middle of the night, because oftentimes people's inability to sleep at night relates to the fact that they're not taking levodopa at night, and it just helps them settle. It also helps them move around. Because she was taking levodopa so frequently every 2 hours, she was not able to ever take her pills on an empty stomach. Not sure, again, what the general knowledge is in the US. What I teach my patients is that we encourage people to take levodopa half an hour before or 2 hours after a pill. So for example, if you're taking a pill at 7 a.m. and 11 a.m., you'd take your pill at 7, then you would you would eat between 7:30 and 9. That would be your meal window. And then between 9 and 11, you wouldn't eat because you take your next dose at 11. But when you take pills every 2 hours, that's not possible. So there is a strategy to try to reduce the protein levodopa interactions, and that's called a protein redistribution diet. And I think Anissa is going to put into the chat later the website that I've developed that talks about all these kind of little tricks, including a protein redistribution diet and how to do it. But the idea basically is that during the day, you eat very little amount of protein, and then you make it up at night. So overall in a day, you eat the same amount of protein. You have to eat protein. Protein is very, very important to your nutrition and health, but you distribute it in such a way that during the day, when you're the most mobile, you don't eat protein. And at night, when you may be more sedentary, then you have the larger protein meal. We continued to address the constipation issues in an aggressive way, and the hypertension, the low blood pressure treatments. So this is just, I just wanted to show you that there is actually some research that relates to liquid levodopa. And this is an old study. It was back in 1998. I think it may be the only study. But in the study, they did 2 parts. They looked at whether the liquid levodopa was effective because it was better absorbed. So if it's in the liquid form, does your body absorb it better? And they looked at 9 patients, and they did what's called a crossover design. So all the patients had both different treatment protocols, one after the other. And initially, some of the patients started with taking 1 tablet of levodopa dissolved in 100 ml of water, versus taking just the levodopa undissolved. And then they looked to see what the peak concentration was and the time to reach peak concentration in those 2 different strategies. So taking a pill with water versus dissolving the pill in the water. And they found that there was really no difference in the peak concentration. So the amount of drug that got into your body was the same. And there was no difference in terms of time to reach that peak concentration. So it didn't get absorbed faster, either in the liquid or the tablet formulation. And then they did a second part of the study, which was to look at the effectiveness of the liquid form. And they took 10 patients with severe fluctuations, and they looked at however much they were taking in a day, and again, fractionated that amount into taking medication every hour. And they looked at the mean UPDRS-4 score, and that's the complications of levodopa. That's that section of the Unified Parkinson's Disease Rating Scale that looks at things like fluctuations and dyskinesia. And they found that 7 out of 10 of the patients really improved. They had less fluctuations, and that was reflected numerically even in the score, but many of the patients wanted to stay on that strategy. And I can tell you, I do that a lot with patients, and it does help them. So the conclusion of that study was that the ability to easily fractionate the dose and thereby administer small, frequent doses customized for individual patients is the most likely explanation for the improved symptom control. So what happened with our patient? Well, by doing that, she did have substantially reduced off periods. She was able to go grocery shopping. She could cook. She started to clean her house. She loved cleaning her house. She went to church. Her hallucinations were reduced with another agent that the cognitive behavioral neurologist gave her, the rivastigmine, and therefore we were able to taper the Seroquel. The Seroquel is an antipsychotic drug, which we really don't like to use if we don't have to. Rivastigmine is actually a cognitive enhancing agent, but in people with Parkinson's disease, it seems to be very good at controlling hallucinations, and that's a first-line approach. The Parkinson-specific urologist provided her with Myrbetriq, which is a medication to reduce urinary urgency and frequency, and she was able to sleep more during the night. And with significant effort, we managed to help her resolve the constipation. She ate a healthy protein redistributed diet, her blood pressure increased, she was getting regular exercise, she had PSW support. All in all, her entire quality of life had markedly changed. She slept at night, she didn't feel fatigued during the day. So unfortunately, that, as everybody knows, Parkinson's symptoms do worsen over time. And so after about 6 months, she started to have problems again. She had problems that we call, the terms are failure of on. That means she takes a dose of medication and it never kicks in, or delayed on, where she takes medication and instead of it kicking in within 20 or 30 minutes, it may take an hour or longer. Unpredictable offs, where even though she should be theoretically in her on state, all of a sudden she turns off with recurrence of symptoms. We looked at our various different possibilities of what we could do. Could we add MAOB inhibitors such as rasagiline or Azilect? But she was taking another SSRI, and there's some concerns that there's drug interactions. We avoided a dopamine agonist, things like Nupropatch or Mirapex or Ropinirole, because she was sort of a fragile elderly lady, and those drugs could all exacerbate hypertension and hallucinations. So at that point, I just wanted to, I see that I forgot that I was going to talk about this, but the delayed gastric emptying, which we had talked about earlier, is really the main reason for the poor absorption of the medication, and you get all those complications with the delayed on, the wearing off, and the dose failure, and why we had tried so hard to manage the constipation and reduce the protein levodopa interactions. But even with all our efforts, that was still happening. So thankfully, we had another option. Now, she was elderly and she was fragile, and she was not really a good candidate for deep brain stimulation. Otherwise, had she been younger without cognitive impairment, deep brain stimulation would have definitely been a good option for her. Instead, in Canada, this system is called Duodopa. In the US, it's called, I think, Duopa. And it's basically a continuous levodopa infusion that goes directly into the small intestine. And as you can see here, the system is such that it's like a feeding tube. So a gastroenterologist puts the tube down through endoscopy. And then there is sort of this pull through with the tube releasing the drug into the small intestine where it's absorbed. So it's not going into the stomach. Outside, there's this little button, and the pump that has the cassette with the levodopa. Now, this is levodopa. It's nothing else other than levodopa, but the company AbbVie has a proprietary formulation where they have concentrated this into a gel, and to allow for this kind of continuous infusion. And so she underwent this procedure, and there is some formulas as to how to calculate how much you need, but then you still have to titrate it to effect. And she got basically 76 milligrams per hour of continuous dopamine stimulation. She did have some extra doses in case she needed it, so she could press the pump if she had some off periods, and within 10 minutes, she would usually have release. And she connected the pump in the morning and she disconnected in the evening. So it's on label for 16 hours of use, but in some cases, we as doctors do 24-hour use, even though it is off label. I'm not sure that the status of the current label. I know that there were some studies being done for 24-hour day use, but we can do it if we need to. And in her case, we did end up doing it. But first we gave her the 150 milligrams tablets at night. We ended up stopping the 24-hour infusion because she started to have more of the sleep reenactment behavior, and it wasn't so good for her. So we kept her at 16 hours. So this is a picture of her with the duodopa. And as you can see, she really liked fashion, and she liked going to the casino, and she did all these things. This was with her granddaughter. I'm going to show you now just a video of her.
High five, Zoe. Hi, Zoe. Yeah.
So what I wanted you to get out of this video was really just, you know, the incredible contrast between that bedbound, anxious lady who couldn't speak to a person that was involved in her family, was able to, you know, be independent and do the things that she liked to do. So sorry, didn't mean to do that again. Okay, sorry. So in summary, non-motor symptoms can fluctuate similar to motor symptoms and may result in substantial disability and reduction in quality of life. Common non-motor fluctuations include cognitive difficulties, mood issues, pain, and fatigue. Non-motor fluctuations can be captured and quantified using the NOMOFA, a validated questionnaire that helps the clinician identify non-motor symptoms that are treatable with optimizing dopaminergic strategies. And treatment of non-motor fluctuations is tailored to the individual and depends on the risk profile of symptoms and side effects. So that's the end of my talk. And now I'm going to get out of the share screen, and maybe we can have some questions. So I'm going to, hold on, how do I do this?
Up at the top, you'll have,
yep.
Yeah, there you go.
Done. Okay.
Awesome. Great. So we do actually have some questions. I think the first one to start with is, I loved it towards the end, you kind of broke it down a little bit and talked about the various expressions of off, you know, the delayed on, the dose failure, the morning off, those kind of things. Could you maybe go into, for those who may be a little less familiar with the terminology of on off, what that means, and then the dyskinesia, like the other side of that. So can you just explain that a little bit more?
Absolutely, absolutely. And again, apologies if I made some assumptions. Everyone has different level of experience and knowledge about the different symptoms and experience. Everybody experiences Parkinson's in a different way. So you may not all be familiar with all the things that I had outlined. But in general, levodopa, so dopamine is one of the neurotransmitters that is deficient in Parkinson's disease. That's one of the main ones. It's not the only one, but it's the only one that we replace. And so when we replace dopamine, we do so synthetically through a precursor of dopamine called levodopa. And levodopa, for it to be effective as dopamine, it has to be metabolized by the brain's own cells that make dopamine. So what happens is those cells degenerate for reasons we still don't know. So those same cells that need to use levodopa, those are the ones that degenerate, and they degenerate over years, probably preceding Parkinson's by decades. And that's when there are the sort of premotor symptoms of, you know, loss of sense of smell, constipation, mood changes, sleep issues, especially REM behavior disorder. And not until 80% of those cells are degenerated do you actually see the motor features of Parkinson's. So at that point, you know, at that threshold where your brain can't compensate anymore, you only have about a 20% complement of those dopamine making cells, which levodopa needs in order for it to be effective. Initially, when people have early stages of Parkinson's disease, they still have a lot of their own dopamine in the brain, and they have this buffering capacity such that I always describe like being in a bank. So you've got a checking account and a savings account, and your bills are due. And if you don't have a whole lot in the checking account, you need to borrow a little bit from the savings every once in a while, but you have enough in your savings. And so you're always okay. You're not having these ups and downs. But over time, you have less and less in your checking, less in your checking account and less in your savings account. You're trying to, so if the bills come up before you have the dopamine in your system. So if, for example, before you take your next dose and you now don't have your own dopamine to cover that buffering capacity, then you really become reliant on this exogenous dopamine. So you have these ups and downs of on where the medication's working and off where the medication is not working. And so the on in general is a good thing. You have less of your Parkinson symptoms like tremors and slowness and difficulty walking, and some of those non-motor symptoms that I had described that can fluctuate in the same way in the off state. So things like fatigue and pain, and some cognitive issues and mood. But in the on state, you may also get dyskinesia. That means that, the brain is really, really good at figuring out how much dopamine you need at any given time. But when we give it synthetically, aren't as good at figuring out when you need it. So you may, based on whatever it is you're doing, you may need more or less, but all we can do is give it at set times. So sometimes we may overshoot, we may undershoot. And if we overshoot, then you get involuntary movements, that's dyskinesia. And if we undershoot, then you get the off symptom. It's not quite that simple. You can also get involuntary movements in the off state. We call that diphasic dyskinesia, and that's right before you turn on and when you turn off, and that usually includes the legs. So it's really complicated to try and differentiate between, is this an on symptom? Is this an off symptom? And as I mentioned, the problems with absorption really, really impact the effects of the medication, especially later on. So it's really, really important to try and optimize, gut motility as much as possible.
All right, since you mentioned gut motility, I will go to some of those questions related to that. One, we had a couple of questions related to the liquid levodopa. So one was they hadn't really heard much about the use of liquid levodopa before. And another one is, if you use it, does it have to be refrigerated?
Those are good questions. I think it does have to be refrigerated. What happens here in Canada, and again, I can't speak as to what happens in the States, but they're compounding pharmacies, and they basically prepare it for you and they give it to you. So you don't we used to make it ourselves, but we don't do that anymore. Pharmacies can make it for you. And we just tell them how many, what is the dose we'd like you to have and when do you have it? And then they figure out the concentration for how much you take. You put it, we usually keep them in dark bottles so that they don't get oxidized, usually used within 48 hours. Yeah.
So another person had asked if they're taking Inbrija, the inhaled levodopa, how is that in comparison to taking a liquid levodopa?
So, I'm going to be a little bit, this is going to be a little bit of a problem for me because I don't use these drugs that aren't available in Canada.
Okay. So there's a few I think they asked about too that I would probably imagine are similar in that.
Yeah. So, the thing is that it's best to discuss with your physician, because sometimes, different strategies, you can try different things and it may or may not work for you, so it's really a trial and error. There's really no downside. I don't know if Inbrija, from what I've seen from my colleagues, a lot of my colleagues have not been hugely impressed with Inbrija, in terms of it's not really solving their problem with the fluctuations. Again, I can't speak from my own experience because I don't have any, but there's really no downside to trying this liquid levodopa. It's so simple. So it's something to discuss with your doctor.
So in regards to the motility issues, someone was saying that they have pretty severe constipation. How would you treat that aggressively? You mentioned that. What would that look like?
Okay, so I mean, that's a really good question. And so what we generally start with is just from a dietary point of view. So it's really important to eat foods that are, like green leafy vegetables, beets and spinach. And sometimes people start their days with smoothies that have, kale and beets and spinach and blueberries. They eat cereal like bran buds, prunes. Really important to drink a lot of liquids, important to exercise. People underestimate how important exercise is, even to constipation. Oftentimes, if constipation is really severe, we start with a clean out, where we actually give them a bowel prep, like from a colonoscopy. It's kind of unpleasant, but you get fully cleaned out. And then we put that, people say, oh, well, now I'm better, so I don't need anything. No, that never happens in Parkinson's. You are never better that you don't need anything. People have to get over this sort of cognitive kind of barrier of, I don't really want to be addicted to this or take it all the time. You're going to need it all the time, because this is what Parkinson's is. So it's better to just sort of be on a regimen and stay on it such that you're not always playing catch up. So then we put people on medications like Restoralax or PEG 3350, I don't know, or Laxaday, I think that may be another brand name in the States, which is, it's not even absorbed into the body. It just sort of draws water into the bowel. Important not to use Metamucil. People don't know this, but Metamucil is, it can kind of gum up the levodopa if it's there at the same time, and then it doesn't get absorbed either. There have been studies in Parkinson's using probiotics. So taking a probiotic every day can really help with constipation. So specifically for constipation, a certain type of probiotic. And then there are other medication, like you can also use Senecot for a stool softener. It has to be a full evacuation every day. That has to be the goal. Yeah, Miralax. I saw somebody wrote Miralax is the same as Restoralax. It's the same thing. I think maybe that's the brand in the US. And some people say, well, it doesn't work. I tried it for 3 days. No, it doesn't work for 3 days. You have to keep doing it. It may take 5 days, and then you have to keep doing it. And if it doesn't work with, one capful, which is 17 grams, then you have to do it, once in the morning, once in the evening. It's something to speak to, an informed dietitian about, or even your doctor. There are other medications, things like Resotran, which is a prescribed medication. There's another one called Constella, which AbbVie, I believe, also makes, which is very effective. So I have, in my 20 years of practice, there has never been a patient that we haven't been able to properly manage in terms of constipation, if people followed through. But it's really important to get over this sort of psychological hang up of, well, I don't want to be addicted to it, because this is really a priority for medications to work and for people to feel better. So I saw somebody asked about the protein levodopa interactions, and that is really, really important as well. So, before we go and increase doses of medications, where there's always a risk when you increase a dose of medication, there's always side effects. Now, of course, we increase if it's needed, and if we believe that increase is going to help the symptom. But I say if, because there are symptoms of Parkinson's that don't respond to levodopa, and those relate to those non-dopaminergic type symptoms, things that are mediated by serotonin and other neurotransmitters that don't respond to levodopa. And those tend to be the midline features. So even on-period freezing or on-period swallowing problems, things like that, giving more levodopa does not tend to improve the symptom control. So we have to kind of determine, does it make sense to give more? But before we give more and risk hallucinations and risk dyskinesia, we want to make sure that the amount that what we're giving is working to its full extent. And that's where the constipation management comes in, and that's where the protein levodopa comes in. For some people, they're so exquisitely sensitive to protein that it makes all the difference. I remember I had a patient who was doing really, really well, and then all of a sudden they weren't. And they called me and said, I'm freezing every day at 3 o'clock. And I'm like, that makes no sense. I saw you 3 months ago. You were great. What was happening? He was eating peanuts at 2:30 before his 3 o'clock dose. And that peanut stopped him from having the effects of the levodopa. It was shocking. But, I often counsel people. And then when I actually, they call me and they say, everything was okay. But then at 2 o'clock, my medicine's not working. And I'm like, well, there's no reason why it would work at 9 o'clock, but then not work at 2 o'clock. The only thing that's different between 9 o'clock and 2 o'clock or 7 o'clock and 2 o'clock is that, you have eaten, you probably just ate lunch. What did you eat for lunch? Oh yeah, a tuna sandwich half an hour before his pill. Well, it's got to be a tuna sandwich half an hour after the pill, so those little tricks, are really, really important. And it takes a lot of work, but if you are informed, you yourself, then you can actually go to the doctor and say, okay, I'm having these symptoms, but I am eating lunch at this time, and this is what I'm eating at lunch. Could this be? And that really, really helps the dialogue. I mean, a lot of doctors don't have a whole lot of time, and they're just like, okay, just take more, and they don't sit and go through these little kind of particulars, not because they're bad or mean, but because it's difficult to go through it. And a lot of times, especially if patients aren't themselves aware, they don't know to report it. So one of the goals of this lecture is to teach you what to report and to think of different, things that are happening that could be contributing to your medications not working as well. Now, on my website, there is...
and I'm going to put that up here in a little bit because I want people to see it. And we did drop the link in, so we'll drop that link in again. But towards the end, I can show my screen now.
Sure.
Reference that. So
because there's actually, I have these data sets of every food and how much protein it has in it. And so, yeah, there you go. So do you want to go into the diet and actually maybe go into reading materials? Go into reading materials. Yeah. And as you can see, go scroll up. And so it has all these sort of tips on how to manage things. Can you scroll up a little more? Because I don't know if we can, keep going. Keep going. How much, it says how much protein, there was a link there to how much protein. If you can just scroll up.
Here we go.
And then if you go to Diet Grail, if you click on that, it's got you can just go to the top, and every food will, you type in which food you want, and it'll tell you how much protein per however amount. Less than 3 grams is considered low protein. More than 3 grams, so if you look at the entire website, there's a whole diet and nutrition area that talks about, if you go into diet and nutrition, so there's all kinds of different things, like if you go down, so protein and levodopa. So you guys can all look through that. Now I have to admit that I'm not a web developer, so there's a lot of content here, but the way it is kind of organized is maybe a little bit complex. That being said,
you have it tabbed here pretty well, like tips on managing constipation, altered textures, maintaining weight, and then the protein and the L-dopa, because we are getting questions about that. Like,
there's a lot in there. There's a lot in there that can be of help. We have a dietitian that we work with that is particularly knowledgeable about Parkinson's related issues. And so all my patients have access to her, but I'm sure that there, if you speak to dietitians or if your physicians have as part of their allied health team, a dietitian, it's really, really helpful. So what I was saying is that we're in the process now. We've just applied for a large grant to the Parkinson Society of Canada in order to revise this website and really, and test it, user test it with people living with Parkinson's to make sure that, it's they can navigate it properly and the content is useful to them. One thing that's on the website that may be helpful as well is we actually worked with a culinary school to develop recipes. So to develop low protein recipes that are really easy to prepare. There's a grocery list at the grocery store, that you can print out, including in sections where to get what. We trialed this with patients and their family in terms of the instructions on how to prepare. We had biochemists making sure about the protein content and so forth. So that may be helpful. Because a lot of people would say to me, well, we don't know what a protein is. We don't know how much protein things have. We don't know, we're on the go. We want to have snacks to take with us, stuff like that. So maybe that can be of help to you. And, this project, we hope to expand.
I love it. I think it's a great resource. I did drop that link again in the chat. So I think you've given some very practical tools on there. So I know people appreciate that. Before we run out of time, I do want to let you know that people are asking about this NOMOFA. So it sounds like, it's done by the healthcare provider, but they're wondering, is it beneficial for somebody to have it to track their own symptoms and where do they get it?
So it's on that website. You can just download it. You can get it. You can get it off the web. It's available. Now, if you were to do a study, you'd have to get permission from the from Movement Disorder Society to use it, and there's a fee, but I don't think any of you guys are doing a study, so it shouldn't be a problem. But yes, it's actually the way we validated it as a self-administered questionnaire, so not it being administered by a doctor. The idea is that patients are able, there's an instruction sheet, an explanation, and then the idea is that patients fill it in themselves. And our validation effort demonstrated that people were able to understand and were able to correctly answer the questions.
And it's on that website. And where on the website?
Sorry, it's the Movement Disorder Society.
Oh, the Movement Society. Okay, yeah. Gotcha.
So if you just Google movement disorder, non-motor fluctuation assessment instrument, Movement Disorder Society, it'll bring you to it. If you are having a hard time, let me know. I'll send it to you as a PDF, and you can distribute it to your audience. Awesome.
And we will try to grab that link. And then in terms of additional questions, there were some, and we're running out of time, in regards to some of these non-motor symptoms. So one person was wanting to know about excessive sweating.
Yeah.
And if that is something
that's a real thing. Yep. That's often seen in the on state where people have where it's excess sweating during the on. Now, the problem with the excess sweating is there's no easy answer. You kind of have to treat the sweating as you would. You have to go through the patterns and see, is there a pattern? Does it fluctuate? And if there is no clear pattern, then this is a non-motor symptom that is non-fluctuating. It depends where you have, for example, the sweating. If it's under the arms, some people get Botox, and that's actually very effective. There's an indication for Botox injections for hyperhidrosis. Now, if it's sweating on your back and so forth, obviously there's nothing to be done about that. Just, ways to keep cool. It's difficult. That's one of the really difficult symptoms.
All right, I found the screen and I'm going to drop it in the chat. And then there was another question about, hold on, I got to get back to my list here. Wanting to know about this. This was interesting. They had no fluctuations until severe insomnia beginning with their second COVID vaccine. Have you seen any COVID related fluctuations, anything like that, or is just somebody's unique experience?
It may be coincidental. I don't see where there could be any biological basis to that, but a lot of people have had all sorts of it may be just true and unrelated that they started to develop, unusual symptoms. I think some people generally felt unwell for a few days after getting the vaccine. I think that's many people, and especially if you have Parkinson's, then, that can really take on a life of its own. But I would imagine that this should dissipate completely. The vaccine should not impact in any way absorption of medication or accelerate brain degeneration or anything like that. So I would reassure you that it's unlikely related to the vaccine.
And then one last question about non-motor fluctuations is that shortness of breath. And I know when you first started your presentation, you had the different, that grid with the different types. And I remember seeing shortness of breath on there. Yep. And you don't always hear about that as a
exactly. That's one of those, rare, but really important to figure out symptoms. And it's captured in the NOMOFA. It is, I see it so many times where patients say, oh, you know, I have shortness of breath, it's my heart, it's my lungs, it's not Parkinson's, it's Parkinson's, you know, especially when it's, I have shortness of breath at this time, but not at this time. So it's definitely something to, you know, have on your radar as a possibility. Now, I'm not saying that just because you have Parkinson's doesn't mean you can't have shortness of breath due to a heart problem. And by all means, it should be investigated. But I have a very, you know, it's on my radar at all times when people tell me, oh, I feel short of breath. And there's no history of heart disease and there's no history of lung problems. So, you know, it's off. And oftentimes when we change the medication, they do a lot better, just like this woman. So she had that as an off symptom.
Well, her transition was incredible. So
Right.
I appreciate you sharing that video at the end to kind of give us a physical viewing of the outcome. So I know we're out of time. I did drop the link to the questionnaire, the scale in there. I know there was a couple of people wanting to know, and if you go to that website, they actually have the scoring information on there. So the link takes you, there's two links. There's one that takes you to the Movement Disorder Society and you just find the scales. The one, and I dropped another link specifically about the NOMOFA, but the scoring sheet is on the website as well. I know people are wanting to know how to get this chat because we've dropped some information in there, including your website. So I want them to have access to that. So if you go to your chat box, you see the three little dots over to the far right, right next to the little smiley face. If you pop that up, that gives you the option to save your chat. It'll save to your device. That way you'll be able to access it later. It is not seen when we play this back in the recording, and it is being recorded. So you'll be able to go back in the day or so and review it, but the chat doesn't show up. So if you want to maintain that chat, you'll have to do that save. And I know that there's been a lot of great information shared here. So please share that chat. Feel free to go back and review the recording because there's a lot of good information. I do believe that the slides will be available on there also. Of course, you'll be able to see them through the presentation. So Dr. Kleiner, this has been a really good conversation. I know that these things are just something that we constantly have more and more questions about. It seems like the more we uncover, the more questions we have. So I appreciate you kind of drilling down and explaining that. And thank you for creating this scale, because I think that'll be helpful for people to identify what's going on and share that with their physicians. So thank you so much for being involved in this presentation. And we have, since you're new as a presenter for us, we have a little tradition at PMD Alliance that we do with all of the people you see on the screen, and that is giving you the wave of gratitude. So from all across the US and even across the globe, we're waving to you to thank you so much for your presentation today. It was wonderful. Thanks everyone for joining us. Check out the recording in a couple of days and check out her website.
Thank you so much. It's really been my privilege. Everyone have a great day.
Thank you. Take care.
Okay. Bye-bye.